I want to welcome everyone back to the Cooper COVID update. This is episode number 3. And if you're new to the program, we're trying to give you what we're doing at Cooper every week in terms of updates for the variety of systems that get affected with COVID. We are well into this disease right now, and we are learning many things, but we still have a long way to go. And our hope is that what we talk about here at Cooper can be helpful to you in your practices as you're either ramping up with COVID or, unfortunately, I hope you're not hitting a second wave. So we have some new faces to the program. We have Dr. Sharad Patel and we have Dr. Emily Damuth, and you remember Dr. Jason Bartock and Dr. Nitin Puri as well. So welcome back to the program, everyone. So we're going to start off with Dr. Sharad Patel, and those of you who don't know him, he is an intensivist. He's also a nephrologist, but he is also one of our echo gurus, and he ties it all together and looks at the body as one rather than a variety of systems. And Sharad, today you're going to talk to us a little bit about mechanical ventilation and the interaction of other systems.
Yep. All right. Thanks, Annie. The approach I'm going to try to have is how am I approaching a newly intubated patient, and how am I working on the mechanical ventilation settings in a way where I'm thinking all organs. What am I going to be doing with adjunct treatments of minimizing AKI, RV failure, core pulmonal, and then what are the things that I'm thinking about that can promote extubation quicker, thinking about it on day one, and trying to minimize iatric injury as much as possible. So in a newly intubated patient, so once the patient's intubated, in COVID patients, I think we've discussed this probably ad nauseum, is that a lot of them are hypoxic and some of them are happy hypoxic. So I'm usually intubating when it's a combination of both. So work of breathing is usually an issue when I'm intubating the patient. So using what Dr. Garinoni talks about with the self-induced lung injury, with the big respiratory pressure swings from negative to positive, can over time lead to worsening injury. So if I'm intubating someone for work of breathing, I am taking an older, more traditional approach, I think, to this, where I'm taking away all work of breathing when I intubate the patient. So the patient's intubated, initially sedated, paralyzed. If the patient has a P to F less than 150, I'm optimizing my ventilator initially. The first thing I usually do is try to get the FiO2 down as soon as possible. One of my biggest pet peeves is just the FiO2 stays at 100% until the blood gas is drawn and we're waiting, and it's usually like a couple of hours before the FiO2 ever gets changed. So I'm looking at the pulse oximeter. So if the pulse oximeter looks like it's 100% or anything above 88%, I'm weaning that FiO2 down quickly. I'm checking an initial driving pressure. So for those of you who aren't familiar with driving pressure, it's basically the difference between my plateau pressure and what my set PEEP is. What I'm trying to figure out with the driving pressure is that what is my compliance at that given PEEP level? And when I'm optimizing my initial PEEP, I'm trying to get the lowest PEEP where I get the best driving pressure, so the best compliance. So if my PEEP is set at 8 and I'm increasing it to 12 and my driving pressure reduces, that tells me that I recruited lung. If I go up to 12 and my driving pressure increases, then I am probably over distending and I'm probably increasing dead space at that point. So when I'm optimizing my PEEP, I'm also thinking about the right heart. So with the COVID patients, there's this phenotype that's been separated with the L and H created by Dr. Garinoni. And what's interesting than what I've noticed is that more of the patients that come in with COVID, the compliance is usually pretty good, especially when the positive pressures introduced. So I'm guessing there were some atelectasis that we improved right away. Now, when the compliance is good, at any given PEEP or positive pressure or tidal volume, there's more of that transmitted into the intrathoracic space. And at any given positive pressure, your transpulmonary pressure, which is the net pressure of what you're putting in and what the chest wall is opposing, so it's the net distending pressure of the alveoli, that will be higher. So if you have someone with very good compliance and you have high peeps and higher tidal volumes on them, the RV is going to feel that. So you'll have a high net transpulmonary pressure and a high end and expiratory transpulmonary pressure. So I'm equating transpulmonary pressure to the strain that the RV is going to be feeling. So I echo everyone who gets intubated in setting COVID ARDS, because there's a very high incidence of cor pulmonale that we probably don't recognize. And so I'm seeing more cor pulmonale if you're using traditional PEEP strategies in someone with better than normal compliance compared to our older ARDS patient, because more of that's being transmitted. So if I see an evidence of elevated RV-LV ratio, I'm thinking to myself is, okay, my initial goal of all of this is to increase oxygen delivery, but I might be working against myself. If I increase my PEEP and I recruit a little bit and I increase my oxygenation a little bit, I may be dropping my cardiac output by causing cor pulmonale with the PEEP. So the net may not change, because if you remember the oxygen delivery equation, the main parameters are oxygen saturation, cardiac output, and hemoglobin. Hemoglobin's not changing. So essentially you're just manipulating the oxygen saturation and cardiac output. So if I do see an elevation RV-LV ratio, I am much more hesitant to go up on my PEEP. So at that point, I'm thinking to myself, okay, I'm going to have to limit myself to what we're increasing the PEEP, and I may not be able to optimally create the best PEEP to optimize the driving pressure. And in that situation, I'm thinking to myself, like, what are other adjunct treatments that I can do to improve the recruitment, VQ mismatch, shunt physiology that you're seeing? That's where the proning comes in. So the traditional proning cutoff is 100 p-def of less than 150. Now, if let's say I have a patient who has cor pulmonale, I've optimized my PEEP to my best driving pressure, and so again I have cor pulmonale and my p-def is 170. I will likely prone that patient at a higher cutoff, because when you prone someone, there's so many benefits, and you could probably have a whole lecture on just the benefits of proning and improving the physiology. But when you prone someone, your pleural pressure actually rises, and usually your net transalveolar pressure, the pressure you're pushing in, will usually get better and lower. So your net transpulmonary pressure usually drops. So as I mentioned before, your transpulmonary pressure is proportionate to your RV afterload. So usually with the proning, the interesting thing that you'll see is that you'll see improvement in RV function when you prone that patient. So by just the physiology you could talk about all day. Again, one could be just improving the oxygenation, recruiting the dorsal aspects of your lung, improving the VQ mismatch. All these things will improve your RV afterload. So on top of the fact that your transpulmonary pressures will improve. So I have a lower cutoff, including the RV in my equation, of proning someone. So I have a very low threshold to prone that patient. In the same way, when I'm thinking about the RV, I'm thinking about the kidney, right? So when you have RV failure, you're more likely to have kidney injury. And when I'm thinking about my ventilation strategies, positive pressure actually has an association with kidney injury. So again, that may be related to the RV effect. So I'm minimizing my transpulmonary pressure by proning them. I would, if someone were to look at incidence of acute kidney injury in COVID patients, prone versus not prone at the same parameters, I would think that you'll probably see less kidney injury in the people who were prone, just because you are reducing the transpulmonary pressure and the net venous congestion and RV congestion when the patient is prone. If I'm seeing cor pulmonale and I'm still hypoxic, I'm going to try to add Velitri or some sort of epoprostenol to further reduce RV afterload. So Dr. Gananoni has mentioned this concept of this, which actually I never heard of before, was just the pulmonary vessel vasoplegia. So typically, your pulmonary vessels are very good at vasoconstricting in hypoxic areas of your lung and vasodilating the areas that are better aerated. That effect appears to be affected in COVID through the mechanisms that I can't begin to understand, but that's thrown off. The proning will help with the overall VQ mismatch as well. because even in healthy patients, there's a less of a gradient in VQ mismatch from ventral to dorsal in healthy patients. So this should improve in COVID patients as well. So I think that the proning will improve the VQ mismatch from that perspective as well. And then adding the velitrium may have an added effect. So I know there's a risk. So this is the first time COVID is the first disease process that I've come to, I have to think about the ethics of our staff and the dangers to our staff as well. And so when you're including that, you may have to break the circuit to start the epoprostenol. So that is an aerosolizing risk. So I'm taking this into account when I'm adding the epoprostenol. So, but that's something I would like to add in that situation. And I think the L phenotype is probably the one that benefits the most, because the L phenotype, you're not seeing the bad consolidation and the alveolar edema that you are with the H phenotype. So I'm assuming there's more of a vasoplasia aspect of that and potentially improvement with the epoprostenol. So I'm prone, I try to do epoprostenol, looking at my driving pressure. Typically I start off with more conventional methods, so cis controlled. I'm measuring my height to make sure I have 6 cc's per, so really standard things that you do for ARDS. Once I've set my PEEP, and when I'm weaning, I usually, for the L phenotype, I'll use the low PEEP ARDSNet table. For the high, for the H phenotype, which is more traditional ARDS, I'll use the high PEEP weaning table to wean the PEEP. Now, those are all the traditional methods that I use. In the H phenotype, I'm more likely to use APRV. So I'm more likely to use APRV. So with the initial settings of my P high being 30, and then my P low being 0, and then I usually set my T low to what you traditionally taught is just basically the T low that gets you 75% of what your peak expiratory flow is. So that can vary, but typically you'll see it around 0.5 to 0.7 seconds or something like that. So I'll set my T low to that, and then after you've set all that, you'll have a net P high at that point. So the good thing about APRV is that you have higher mean airway pressures. So the mean airway pressures, by having such an long I time at high pressures, oxygenation and recruitment are proportionate to high mean airway pressures. Now, I think if you have the L phenotype where you're transmitting more of this positive pressure, you might get into trouble with core pulmonal more often if you're using APRV in the L phenotype, where there's not as much inhomogeneity of the lung, the alveolar collapse, or not as much to recruit. So I think APRV will probably work better in the patient with the H phenotype. And if you're thinking about keeping them awake, so you can spontaneously breathe, it's more comfortable for the patient. I don't use APRV as much in my practice because I really, like I mentioned in the beginning, I have a very low threshold to sedate and paralyze because I'm trying to take the negative big pressure swings away, which is one of the big probably promoting factors of progressing in the lung injury in these patients. So, and very early, especially if the PDAF is less than 150, I'm sedating and paralyzed. And in APRV, and at least in my practice, if they're not spontaneously breathing on top of that, I'm starting to run into more hypercarbia and acidosis, which I'm setting my pH goal to be 7.15. So I'm okay with anything above 7.15, but I still, more often than not, I'm running into the problem with hypercarbia and pH issues with APRV. So I'll use APRV if I'm thinking that this patient is doing fine with spontaneous breathing and workup breathing is not as much of an issue. So those are kind of my basic integrated. So I try to integrate echo as much as possible. I'm trying to get them dry. So I'll initially do an IVC evaluation, a portal vein evaluation, look for organ kidney congestion on top of the RV evaluation. And then I'm also looking at their initial x-ray and then what their x-ray looked like when I intubated them. Because I think a lot of these patients have a component of pseudo-ARDS. They're coming in inflamed, they get the boluses, the 3 liters, and then they have bilateral infiltrates or they aspirate. So if there's a rapid change in their imaging, the more rapid the change, the more likely I think they have a rapid reversible process on top of their COVID. So this patient I'm being aggressive on, trying to get negative fluid balance, so 1 to 2 liters the next day, especially if there's portal vein pulsatility, any sign RV-LV ratio, and then a dilated IVC as well. So I try to do the fact trial kind of protocol to keep the patient as negative as possible. You shouldn't see AKI if there's signs of venous congestion.
Gotcha.
So if there's AKI, it's from probably other aspects of it. Is it a shock, or is there a thrombotic microangiopathic component?
Gotcha. So
it sounds like
it sounds like what you're doing initially when you start off is you're getting the patient tubed. You're starting with what we normally do, and you're doing it really well. You're using the lowest P possible, getting your FiO2 down. Next thing is you're looking at your driving pressure.
Mm-hmm.
If you're still having a person who's hypoxemic, going right to proning them early on. And then if you're still having trouble, or in the interim of any of that, there's any evidence of RV dilation or congestion in the system, adding in your pulmonary arterial vasodilators on top of that. And then for the people who maybe have the more traditional ARDS, the less compliant lungs, going to an APRV strategy possibly, as long as there's no evidence of worsening RV congestion.
Yep.
Is that fair? That's great.
Yep.
Well, thanks for that summary. Anyone else have any comments with respect to that, or do they do something slightly different?
Yeah, I think that was a really great summary, Sharad, looking at both the physiology and your practical approach. I don't really have any comments. Trying to differentiate between that L and H phenotype, I think we've all, globally taken that as part of our treatment strategy. I'm not seeing as much of a clear line, I think, as I was maybe 2 months ago. But what I will say, I have a very similar application of mechanical ventilation as Sharad does, especially with regards to APRV. And I know that there's a lot of folks out there that are very comfortable with the use of APRV and may use it as their primary mode of mechanical ventilation. I don't think that there's great evidence to say that it's harmful, as much as, as we focus on preventing mechanical injury, minimizing transpulmonary pressure, and worrying about mechanical power. I think that we all have concerns about where APRV could take someone. But all that being said, I will say for, a handful of patients that sort of showed up mixed with sort of, radiographically and probably early in their disease course looked like an L phenotype, but didn't have the best compliance. I saw that very much in my morbidly obese population who just was intubated. So they're probably a mix of, alveolar injury and inflammation, but also loss or probably de-recruitment from obesity. And, I think for the handful of patients that I use APRV in, I can think that if the people who were most responsive were those morbidly obese patients, probably because of a combination of atelectasis on top of their COVID disease. I'm not saying that every obese patient I see, I would choose APRV first, but I think that it probably makes sense since we don't know what their true transpulmonary pressures are because of their body habitus. So something to take into consideration when looking at different phenotypes of ARDS patients, not just from disease, but body habitus.
Fantastic. We're going to turn things over to Dr. Emily Damuth and a little introduction because this is her first time on. She's an emergency medicine physician. She's also a critical care physician. She has a killer outside jump shot. Anyone that's played her in basketball knows this. And she's also a tremendous, wonderful human being that we're all better people for knowing her, but also how she is with her patients. And to exemplify that, and she's not going to like this, I'm going to give a shout out to NJ Magazine, where she was written up, her care was written up as a feature article. And I'll put a link in the show notes for anyone that wants to read it, because it's definitely worth a read. And not only during this COVID time, but anytime as being a physician, that article brings us back to what we should be doing as physicians at the bedside. So it was a wonderful article to read. I know she hates me for bringing it up, but I'm going to do it anyway because all of us really love her for being that physician. So with that introduction, Emily, what are you going to talk to us about today?
Thanks, Amy. So I thought I'd talk about three things that I think are really inextricably linked that are particularly sort of barriers for us in a pandemic situation. And that would be, visitation, so family visitation, family communication, and end of life. I've actually tried to look in the literature at prior pandemics dating back to, even 1918 with the worst pandemic in history, and looking at even SARS and MERS and this issue of communication and visitation restriction. And I wasn't really able to find much in the literature, but I think we can suffice it to say that globally, we as providers, certainly in my short tenure career, have never seen anything like this as far as, having to restrict families at the bedside supporting their loved ones. So, that was certainly for good reason to, make it so that we can practice social distancing, so that we're not having further transmission to family members from patients that are infected in the hospital. And clearly, particularly more at the beginning of the pandemic, just the PPE shortage, these were essential measures. But nobody felt it more than the families themselves. Many of our patients in the ICU, while some of them are aware of having supporting family members at bedside, probably most of them are not. They're sedated and deeply sedated and paralyzed. But for the family, this is just an impossible situation that's truly tragic. And if we think about the challenge for the family that it is, oftentimes the family will be at the bedside most of the day. And by being forced to be in their homes, they lose all those cues that they normally would have. Like, oh, today was a good day. The care team didn't run in and do an emergent procedure on my loved one. They lose all the cues that things are going well, and instead wait for the phone to ring and just probably assume it's either a tragic phone call or potentially a very joyous phone call, but you never really know. And so I wanted to talk a little bit about some of the ways that we at Cooper tried to work through this challenge of having visitation restriction. And, I think we're still trying to come up with new ways to make this easier on families, but also I think we have to think about ourselves and how the psychosocial toll it also has on providers to be sort of the surrogates at the bedside sometimes for patients because their families are not there. So one of the ways that we kind of circumvented this at Cooper with video phone calls, and I think this is now becoming more widespread, allowing either the nurse or the provider, the physician holding the phone so that, family members can just see their loved one and try to interact with them, but at least talk to them and support them in that way. The other thing that we were blessed to form a program and have incredibly hardworking and caring students that over a quarter of our graduating / some had already graduated class wanted to be a part of our efforts in the pandemic, and actually formed a program called Critical Connections, where they actually daily would listen in on rounds and then in real time inform families right after they heard rounds and the plan for the day, how their loved one was doing, what the plan for the day was, so that the families knew that every single day they would have at least that one phone call during rounds, so they didn't have to wait for hours till the team was done. The other way that, I know that personally that I've tried to further augment this is, I know that the medical student would call during rounds. At the end of rounds in the afternoon, we break up. And with 3, 4, 5 people on the team, you can really break up the family phone calls and make sure that now everyone gets one, but not just one, but 2 phone calls, leaving maybe the more sort of urgent and heavy conversations for attending level faculty or fellow level faculty. And then finally, certainly keeping within the protocol at a particular institution, but at Cooper, we sort of modified as we went with our protocol and are now able to, in end-of-life scenarios, get visitor exception and bring, a family member to the bedside to support their loved one. And, reading and reflecting on some of the palliative care literature, if we think about what these families are going through, the risk factors for having sort of poor bereavement or a complex grief reaction with death, which clearly there's always grief with death, is not being prepared, having it be a sudden death, having it be a hospital-based death or a death in the ICU, And I think that most of those factors I just mentioned, we can't impact, but preparing family members. And it's truly, I think that these touch points, that calling them multiple times a day and keeping them in the loop and having these conversations frequently, I think allows them to sort of prepare for the trajectory that you're communicating. Other features that make complex grief more common are having a family member die while intubated, family members not being able to say goodbye. And again, I think that even in the absence of visitor exception, that's where video comes in, that while it's not ideal, that form of communication can benefit families. And then finally, thinking about the positives, how can we as caregivers sort of mitigate the grief and bereavement, just of having a sick loved one in the ICU or a death. And really what family members report is just the sense of compassion from the caregiver team, the team conveying, empathy and truly caring about their loved ones. And I will say that, as difficult, sort of this to me was a relatively, the magnitude of this issue was sort of, unexpected when I thought it, because, I don't think when we got into all this, we knew that there was going to be, a large surge of patients that were ill, but I don't think, at least I didn't think through the ramifications of how that would all impact families from the get-go. But then within, the first week on service, you really realize that this is one of the crucial factors that impacts just how difficult this pandemic is. And so I think that, we can truly convey empathy and caring, even though we're restricted to mostly video and phone call interactions. And I was actually talking with Jason the other day that, some of our most meaningful relationships have formed with families in these past few weeks, and trying to reflect on, why would that be? Because normally they're just at the bedside or even participating in rounds. And I think to some degree it's, us displaying and the families seeing how much we care by making all those efforts to make all these phone calls and, allow them to see their loved ones and them knowing that we are like kind of acting as an extension of them at the bedside. So that's kind of been the surprise, happy surprise, is that despite all these barriers, we've still been able to connect with families and they understand why it's limited, and they're just extremely appreciative, which just makes it even harder, honestly. But I think that was a pleasant surprise. So that's really most of what I wanted to talk about. I think we also have to acknowledge in each other that when, we are serving as more of a support person for patients, that when deaths happen, they're very difficult for us as providers, and kind of picking each other up. I know that we had a little bit of a tough week last week, and I think that that helped. So just acknowledging that your colleagues, the nursing colleagues, the other providers, it's hard for us to witness the suffering and then know that their loved ones can't be with them, or maybe they can, but in a very sort of shortened duration right at the end of life. So I think we have to sort of pick each other up too. Because this is hard on all of us, but certainly number one, it's hard on families.
Emily, one of the things I find is most people still don't know what intensivists are. Have you? Is that your experience? No, I'll say how it leads into this conversation.
Yeah, I think to some extent, yeah, that they don't necessarily know. I think they're learning through all the phone calls and talking to our team, what roles we play. But yeah, I think the complex inner workings in the ICU with all the consultants, although probably less consultants during the pandemic, I would say, is very confusing. So yeah, I agree with you. I think that until you live it through your family member, it's kind of hard to figure out all the players involved and whose role is what.
Yeah, and so the reason I'm saying that is that like this pandemic, more than anything that's happened in the, I think as you say, critical care came about in the late 60s or mid 50s, so you'd say 70 years, it's put us in the spotlight. And it's a very unusual spotlight because we're making phone calls to be like, hey, this is what's going on with your family. We're doing the best we can. And, but, part of our speciality is, and maybe it's all in medicine, but it just feels like it's more with us. And maybe that's unfair for me to say, is that empathy. I mean, end of life is part of what we do. We have no choice, right? It used to be the old numbers that 1 in 5 Americans died in intensive care units. I don't know how inaccurate that is, but it's part of our everyday life. I think it's a very unique person who goes into critical care because you end up having to deal with death. And, Daniel Lamas wrote that piece in the New York Times saying, patients shouldn't have to die alone. And they're with our critical care nurses and they're with us. And one of the most poignant things Emily said is it's all right to do FaceTime when people are getting better, but it's not all right when you're not getting better. And so my question to Emily is how do you think this will change the public's view of us as intensivists? The view inside medicine's view of critical care has probably been, our stature's been raised, but I don't know. Emily, what's your opinion about outside of the hospital or the medical field? How will people look at us in this moment or in going forward?
I think for those that dealt with it firsthand, and had these conversations with us day in and day out and kind of thought through the risk imposed to the healthcare provider and, yet how we don't question that at all and do everything we can for their loved one. I think they're very much impacted. I think for a proportion of society who really didn't have, a loved one get very ill or wasn't truly face-to-face and front and center with the frontline workers, I don't know how much it will change the view from their standpoint, but I think overall people really have taken a step back in this pandemic and think, this isn't the first risk to our health that we expose ourselves to as intensivists or as physicians or advanced care providers or nurses, and I think certainly not the last. And while on the one hand, I don't feel it's heroic to do what we do, I think we all do it because we want to, like you said, Nathan, we look to step into these moments, not back away, having these hard conversations, displaying compassion, really truly feeling empathy. And that's what drives us to do what we do. But, it is interesting how the public persona or perception has changed. I think to some degree it has, but unless they're really, front and center or having a close family member be sick, I think it's hard to really understand, the depth of what we do.
Yeah, if I might jump in, one of the things that you see in New York City is this 7 p.m., which is still happening, where people are screaming out their windows, honking their horns, banging pans, for healthcare workers in general. But I think the public is getting it. Now, I don't know if the whole public still gets it. There's still these protests where people are wearing masks, the nurses wearing masks and people yelling at them. And even there's still assaults happening and insults happening at gas stations and supermarkets when people are going in their scrubs. So I don't know if it's fully there. But I do think that people have insight into what we do. For the first time, healthcare has been seen as equivalent to a soldier or a police officer or a firefighter, because everything else was closing down and we're still going to work every day. We're working harder. They see the pictures of us with N95 masks. I say us as healthcare workers, nurses, respiratory therapists, everybody. But people for the first time are having insight into this unknown entity, which is putting people at death's doorstep, and we're going to work. And we never said no. We never protested. We never went on strike. I feel like there's a respect, even on a personal level. I can tell you that people are giving me stuff or they're waiving fees. And I never asked for anything. I think of it like Emily does. This is our moment, but it's my job. And I'm lucky that all the training that I've done, I could do the things I was trained to do. But other people like give you stuff and they're like, no, thank you for what you do. I can't imagine what you're going through. And so I do think a fair bit of the public has been changed by that. My only hope moving forward is that they don't forget the risks that we take when all this is done for every day that we go into work. And I'm not asking for people to bang pots and pans for me or nurses or anybody else, but I do think that the perception of physicians who are just rolling around, who in fancy cars, who don't care about patients, I hope these moments remind people that this is really why we do what we do. And I think it will for many people.
I think that's a really great point. And, you know, and I also think that, you know, I hope that the perception of critical care and intensive care medicine, you know, the you know the weight of what we do doesn't have a negative impact on our field as well. You know, when you think about you know, the amount of isolation I think a lot of us feel even today. You know, many people choose not to go around their loved ones. Many people choose not to pick up their children still. You know, that can be really difficult when you're working probably twice as much as you've worked in the past, not having, you know, any semblance of home and work balance and fear for the people that you love. And also every one of these conversations that we have, there's so much weight behind them. I mean, we've developed I mean, I can say, you know, I taught, you know, pre-COVID, talk to families, engage with families. It's always been a very big part of our practice. Now, you know, we know so much more about them. You know, we have this intimate connection that I haven't had previously. And, you know, even after their loved ones leave the ICU, you continue to follow up with these people because you develop a relationship, and sometimes it's hard to let go of that relationship. There's a lot of weight behind that. And then each one of those conversations, especially with the amount of media coverage, you have to be very careful of the way that you present something that you still don't truly understand, you know, to a family member, so that you don't find yourself, you don't dig a hole for yourself, or you don't give too much hope, or you give enough hope to keep them going. It's more strategy than I've ever experienced on the telephone. So I know I worry about, you know, our, you know, the intensivists across the nation, across the world coming out of this being a little twitchy, or not being able to socialize, or, you know, or not being able to get that time back, and the impact that it will have on their mental health. And we've already seen, you know, people lost because of that. So I do think that, you know, we have to, you know, we have to engage our colleagues and make sure that they're doing okay from a mental health standpoint.
Excellent point. Yeah, we all have to check on each other. Very, very important, and make sure that when the days get long, we keep a smile on our face and let people around us know that it's going to be okay. And just telling people it's going to be okay. This is going to be okay, but in the midst of it, it's hard to see the end.